Okay, so when I left off yesterday, I was talking about the pharynx, which is considered the throat, and we're talking about just the back, part of the throat, which it does have two passageways that you need to know because this picture will be on the test. Um, Sorry, let me get it in a different view. There we go. Um, a nasopharynx, which communicates with the nasal passages, and the oropharynx, which communicates with the mouth. Just some other structures, again, hard palate, which is like the roof of the mouth between the teeth, which is bony, does separate the nasal cavity from the oral cavity. This right here just kind of looks like a hill. That is the tongue. And then this soft palate is the divider between the nasopharynx and the oropharynx. And then the openings here, dorsal, this is a smooth tube. So the difference is the esophagus is a muscular tube. It's part of the digestive system. The trachea actually looks like it has these bumps, which are tracheal rings, and that is the opening to the airway. And then if we move on to what the larynx is, this actually connects the pharynx to the trachea. So right here is the larynx, and that is the opening to the trachea. So the larynx, which is the voice box, is part of the airway. Now, the larynx is like a structure of cartilage and muscle. So it's kind of considered one piece, but it is made up of different things, different types of cartilages. It does have a hyoid bone. There is a U-shaped bone underneath that supports it, and the hyoid is one of those floating bones because it doesn't have a connection to the axial skeleton. It doesn't connect to the appendages. It kind of is in the throat just as a supportive mechanism. Now, the opening to the trachea is a flap here, which is called the epiglottis. And then on the sides, you have two arytenoid cartilages, and then thyroid and cricoid. The two things that you need to know, obviously that the larynx is the voice box, and it's the opening to the trachea, or the airway, but you do need to know the epiglottis and the arytenoids, and I'm going to talk about those. The epiglottis is the most rostral cartilage, meaning it's the one closest to the nose, but that is a protective flap, and it's made up of the cartilage, and it will open when the animal is inhaling and exhaling. It will close when the animal is eating or drinking. So it's supposed to be protective so that food or water does not get into the trachea, saliva. Sometimes it's a joke if someone says, "Ooh, that went down the wrong pipe." What they're meaning is to talk, you have to move air. And if you talk, your epiglottis is open. Now, sometimes I have a bad habit, and I drives my family nuts, but I might eat and you're talking at the same time while you're eating. Well, if you're talking and your epiglottis is open and then you're eating, there is a chance you could inhale, and then the cough that happens is a protective reflex so that protecting the airway. So in normal function, that epiglottis will open and close. Now, it's important to know when we do anesthesia, because when we go to intubate an animal, the epiglottis, sometimes we have to take our endotracheal tube and sometimes it gets stuck in the soft palate. We kind of push it down, and then you can pass the endotracheal tube through the arytenoid cartilages. Now, the voice box portion, or the arytenoid portion, is you've got the vocal cords are attached to the cartilages. So what we have, now we're past the epiglottis. Okay, so epiglottis is down. When the larynx, so there's arytenoid cartilages, and they are attached to muscles. And so the muscles will pull the cartilages open and will relax when they close. Now, attached to those arytenoid cartilages are those vocal cords, or the vocal folds. So when the animal inhales and they open, that's what makes the sound. And it will form, now there's false vocal cords. I just want you to know the vocal cords or the vocal cords are attached to the arytenoid cartilages, and then there's muscles, the laryngeal muscles attached to the arytenoid cartilages, and that's what controls them opening and closing. Now, the job of the larynx, it is considered upper airway, and it prevents or it produces a voice, but it also prevents substances from getting into the trachea. Now, the epiglottis should be protective and closed, but the arytenoid cartilages are also going to close when the animal is eating and drinking. So those should close as well, and they will control the airflow. So those are the jobs of the larynx: to produce the voice, to protect, for inhalation of, as it says, foreign matter, food or water, whatever, and allow air to come in and out through the trachea. Now, what I want to do, and see if my computer is going to cooperate. See if I can show this. Can someone just verify that you can still see my screen? Okay, good. Oops, get back. Okay. Okay, what I want to show in this video is, so let me talk about a condition called laryngeal paralysis, and this kind of explains the larynx. It's why I show this video, not to mention it's a disease that you can see in animals, but there is a condition where and it's usually is a nerve muscle issue, where the larynx, instead of opening nicely and closing, it doesn't open all the way. And so if you can imagine, if the animal is trying to inhale and it doesn't open, we're going to have a problem. They're not going to be able to inhale. So I do want you to watch this case. I want you to watch this dog breathe, because especially when I have you in anesthesia and I talk about pattern of breathing, work of breathing, mucous membrane color, I just want you to watch what is happening.
This patient came in for breathing problems, and we put him in the cage. He was doing all right before, but the anxiety brought on the severe asthma, kind of like you think would be an asthma. What it actually is older labs can get laryngeal paralysis, and you can hear he's just got a whistling wheeze in the front of his throat, and that's because his larynx, the opening of his trachea is very small.
Can you not see it now? Because I have it really, huh?
We can, but it's just going so slow that it's like frame by frame. So it's not really a video that we can watch, you know.
Let me try to back it up again. Let me know if it's better.
Anxiety brought on the severe asthma, kind of like you think would be an asthma. What it actually is older labs can get laryngeal paralysis, and you can hear he's just got a whistling wheeze in the front of his throat, and that's because his larynx, the opening of his trachea is very small. And he's got trouble moving air through it, and he's gagging because he thinks there's something in the back that he has to get rid of.
And what happens is their larynx, which is right here, their voice box, they get paralyzed, and it closes off.
So here's the obligatory diagram you always have to see, but on the left you can see that's looking right in.
He's going to explain this, but I want to show you. I thought maybe if I minimize the screen, it wouldn't be so choppy. But here is a good drawing of, here's the muscles, and these are the arytenoid cartilages, and you can see these vocal cords or vocal folds. And you can see, normally these muscles will pull these cartilages open like a curtain, close when they're done, open when they're inhaling. And then this right here, this little V, that's the flap of the epiglottis. So what happens in laryngeal paralysis is that the nerve or innervation to that muscle, and a lot of times this is genetic, because I tend to see this, it's almost 8 to 10-year-old Labradors. I mean, I think back to all the laryngeal paralysis cases, and it can happen in other dogs, but I've seen it in older labs, and it's kind of like just a degenerative disease. It just happens when they get old. But you can see what happens is this is an opening. So the animal is trying to breathe. Instead of having this whole opening to breathe, they're trying to breathe through this little opening. You can see this dog is going, because he's like trying to pull in, and they get panicky. They excess salivate because they feel like something's stuck in their throat. So they tend to produce a lot of saliva, which doesn't make it any easier for them to breathe. Kind of compounds the problem, but he'll explain here.
Windpipe folds around it are the arytenoid cartilages and the vocal folds, and they usually get pulled open, like you see on the left. But in a paralyzed larynx, the trachea gets covered up, and you only have a really tall, small hole there at the bottom for the poor animal to breathe through, and that's what's happening.
Let's just pretend like this tracheal tube is a trachea. And let's pretend like this is the larynx, and this is the opening of the trachea. These are arytenoid cartilages here, and as an animal or we breathe, the muscles retract the cartilages to open up and let the air down into the lungs, and then they close. And with each breath,
the owner says he comes out of these, but definitely the only treatment is surgery. So I'm monitoring real carefully after the IV shot of dexamethasone to see how he does. He's starting to move more air.
The surgeon will come and he'll tie back one of these arytenoid cartilages so it stays open like this. The only trouble is when they swallow, there's a membrane that covers this called the epiglottis. And that membrane, if they don't, these will close and that membrane will cover it when they swallow. Unfortunately, if this is open like that, they could inhale food down there and get pneumonia.
You can see his gums are still somewhat pink, but his tongue's bluish. And he's just having a heck of a time breathing, moving air. After a few minutes, you can see his breathing's much better. I gave him the cortisone IV, and I didn't give him a bunch of oxygen because, again, sometimes putting him in the face of that cone will stress him. I didn't intubate him.
So I don't know if you can see, obviously you saw the color, you see the saliva, but that lip movement, that when animals tend to smile or tend to use their mouth and exaggerate their nostrils, they're really trying to pull air. It's an indicator of increased effort. Now, the dog got a steroid. What the steroid does in this case is a lot of times with laryngeal paralysis, sometimes they have swelling back there, and the steroid will help decrease the swelling, and it can help them breathe. I mean, that's a very temporary thing. Stress tends to exacerbate this, and a lot of times these dogs, I mean, surgery is the only option, where they do what's called the laryngeal tie back. Like he said, they tie back a cartilage. The problem is that'll help them breathe, but the cartilage being able to close is protective. So if it's permanently tied back, if the epiglottis dysfunctions, then it's going to be much easier. They're at a very high risk for aspiration. I mean, it's not a perfect scenario. You know, you got to help your dog breathe, and, you know, then you're just risking pneumonia, which you feed them slowly. There's techniques to help feed them so that they don't aspirate, but it's going to always be a risk.
If you intubate him, you have to take him off the intubation, and sometimes that alone will cause a problem. You can see after just a couple of minutes, he's much better.
That was pretty hard to.
Okay, so I think, the reason I kind of like to show this is that it shows the anatomy, I think, well, of that area. It explains the job of the larynx. And, obviously it's one of the conditions that we can see. Do you have any questions about that? Like laryngeal paralysis or the larynx itself? Okay. Okay, so we're moving down. We are still in the upper airway. But after the larynx, so you have the epiglottis, you have the larynx, and that controls the opening to the trachea. Sometimes in people, I always call it trachea. It is our windpipe, just right here in your neck. So our larynx, and in animals, if you feel your animal's neck and you feel like this kind of hardened structure, that's where the larynx is. And then the trachea is right below. So what you're looking at here is this is the epiglottis, this is the larynx, and then it opens to this windpipe or trachea, which is, it's fibrous, it's dense connective tissue, but it also has some smooth muscle. So wrapped around the trachea is that very delicate, smooth muscle, which if you remember, smooth muscle is autonomic. It's controlled by the autonomic nervous system. So in sympathetic stimulation, those muscles dilate, will open up the trachea to accommodate more air. And then when you get to parasympathetic, they go back to their normal diameter. So the trachea, not that it's going to get super big or super small, it can expand and contract because of the smooth muscles that surround it. But they're cartilage rings. So the trachea, that's why it looks like on the picture it's got bumps. It's a series of rings with connective tissue and smooth muscle. But then what it does, it's one tube, but then when it gets into the thorax, it's going to bifurcate or split. And then the trachea is going to go and it's going to split into these bronchus. There's a right bronchus and a left bronchus. Now the bronchus is going to enter the lungs. And so you have a right side of your lungs and you have a left side of your lungs. So we've got two sides, but the trachea is the main pipe. And also what I talk about in anesthesia is when you put a tube in an animal's throat, when you put it in the trachea for anesthesia, a lot of times these tubes are pretty long, sometimes longer than the animal needs. You never want to put a tube all the way in, because what happens is you could push it in the trachea and you could go to just one side of the lungs. The problem is both sides of the lungs need oxygen and anesthetic. If you put a tube in a patient too far, you can go to one bronchus. And sometimes these animals won't oxygenate well. They don't breathe well during surgery. They start turning blue. They have problems with their carbon dioxide. And it's because you're not getting oxygen and anesthetic to both sides of the lungs. So one of the things you do when you're an anesthetist is the students put the tube in. I have them feel for the thoracic inlet. Now, if you guys, where a dog's neck meets their shoulders and then they've got kind of like these divots, which is kind of called the jugular groove. You learn that when you draw blood, but if you put your hand in the neck and you reach in and feel, this is about where the trachea bifurcates. Like our bifurcation is right here, and it splits to your right and left sides. In a dog or a cat or anything, at the base of their neck is where the trachea is going to split. So I have the students hold here and they move their tube back and forth so they can feel the tip of the tube. You don't want the tip of the tube to go further than the thoracic inlet, because then you might go on one side. I know sometimes a lot of you guys, you might get a job, they might train you on the job, and sometimes people that don't know what they're doing, they just take the tube and they just think, I'll put it in all the way. The problem is a lot of animals don't need all of that length, especially cat tubes. Cat tubes are really, really long. So the landmark for placement, and this is why it's important to know, is the thoracic inlet. That's where the tip of your tube should be. So you go, so oxygen and anesthetic do go to both sides. Now the trachea itself, it is technically a C-shaped cartilage, meaning it's not a complete circle. It's a C-shaped, and you can see on the inside, this is a mucous membrane lining. You've got the tracheal ring. We've got some muscle, but you have a band of muscle that connects the C. That's what makes a complete circle. So, and this smooth muscle, this is what will constrict or expand based on the stimulation from the nervous system. So that muscle will expand and contract. So this ciliated lining is protective in the trachea, and there should be mucus. I mean, a lot of times if you pull an animal's tube after surgery, you'll have mucus on it from their trachea. It's just kind of, and sometimes animals produce more than we want, but it's a common finding. The other thing on here, does anybody know there is a species that has a complete ring to their trachea? It's complete cartilage ring. So they have circle cartilage instead of a C shape. Does anybody know? Yep, a bird. So birds have complete tracheal rings. Now what's interesting is if you see a bird when they completely like turn, especially when you look at an owl, they look like they completely turn their head. Because sometimes, one time someone asked me, well, why are they complete tracheal rings? And I go, well, we can call God and ask him. But I said, if you think about how a bird moves their head, I think it's an adaptation, because think about it. If I had a tube that's not complete and the bird twisted, it could compress that tube. But the fact that a bird has a complete tracheal ring, when they twist their neck, it's going to stay open. It's not going to compress as easily. So and I even asked Neemer once, because I was like, okay, I got a bird question. And she was like, well, I don't know why they have complete rings. And I told her my theory with them turning their head, and she's like, that sounds good to me. So I'd have to do some more research, or maybe Chance, our bird person, wants to do some research, but they are complete tracheal rings. Every other species has this C-shaped cartilage. And the band of, now it's like I said, it is connected. It's not like there's a big gap here. It's connected with smooth muscle. So all of what I just, evolution, I think evolution, them twisting their head, it's like, yep. And the nice thing, like when you guys restrain birds, and my one practice, my doctor was starting to get into avian medicine, so I'm not a huge bird fan. But when you hold a bird, you can wrap around behind their head, and you can really grasp them. You have to grasp them pretty hard, but you run less of a risk of collapsing their trachea. I mean, you have to be careful, but you can hold them pretty decently around their neck and their head without a problem. Okay, we're moving on to the lower airway, or the lower respiratory tract. So the digestive, so I said, I thought it was because I don't know, Emily, what you're meaning with the digestive, because so you've got the esophagus, and then the trachea is your airway. So I don't think it has a digestive reason, unless you're, like I said, I'm not a bird expert. I will tell you, I've worked a little bit with birds. That might be a Neemer question. Okay, let's talk about the lower respiratory tract, and it's sometimes called the bronchial tree, because if you look at this picture, if you flip this upside down, this is like a trunk, and these are like the branches on the top, and it branches into the lungs. So sometimes when people call it the bronchial tree, it's because it goes from a big branch to a smaller branch to an even smaller branch to smaller branches as you get into the lungs. So the lower respiratory system, and you should add the lungs here, but it is the lungs, the bronchi, the bronchioles, and a bronchiole is just a smaller bronchi. And then you're going to get into alveolar ducts and alveoli. And the alveoli is the most terminal end of the respiratory tract. So the most rostral, meaning the beginning, is the nares. The most distal or terminal end of the respiratory tract is the alveoli. Okay. So let's talk about the bronchial tree. And we're looking at the trachea. Now you've got a right and left bronchus that enter the lung. And then you can see these series of tubes. Now, these tubes, just like the trachea, have a little bit of smooth muscle wrapped around. So again, in nervous stimulation, and when you've got sympathetic stimulation, if you remember, I said your bronchioles dilate because you need to breathe more. And then when you calm down, when you come out of, into parasympathetic, then they're going to go back to their normal diameter. So the smooth muscle in the bronchial tree or the bronchial system is what controls the diameter of the bronchioles to accommodate more air or, go back to normal size. And again, those are controlled with the nervous system. The other thing I'll mention, and if you know someone with asthma or if you yourself have asthma, when people have asthma, they tend to have narrowed, their bronchioles are too small, their bronchial tree, and they get constricted. And that's why they feel tight chest, can't breathe. And when they take an inhaler, most inhalers, now inhalers can contain different medications. Not every inhaler is the same, but in general, an inhaler usually contains a bronchodilator. So that medication gets inhaled and it'll cause those airways to open up. So people can be put on there's medications that are under the category of bronchodilators, and they cause those muscles to relax. But if you remember the receptors, you've got alpha 1, beta 1, beta 2, when the nervous system sends the neurotransmitter, it causes that either relaxation or for it to go back to normal. So again, when you look at these bigger branches, you're going to have a bronchi, and then the little ones here are going to be bronchioles. And then the bronchioles, which are the small, and again, this is going all the way inside the lungs, are going to connect to alveoli. And alveoli is a thin-walled sac, and it's surrounded by capillaries, okay? Inside this sac, so if you look at one sac, they're air sacs. So if someone says the air sacs of the lungs, that's the alveoli. Now, it should be, excuse me, they should be air-filled. Think of it like a balloon. They're little balloons in the lungs. Now, inside that balloon, they contain a fluid called, or a fluid, and it has something in it called surfactant. Now, the surfactant, now, this is an air sac. It's not supposed to be all fluid. I don't know if you've ever gone to get helium balloons. If you go to like the party store, and sometimes they're like, hey, do you want the fluid inside? It helps keep the balloons inflated longer. And sometimes they'll squirt a couple pumps and then you inflate your balloon. And like I said, and it does work, because at one time I did it for my kids' parties. Those balloons lasted forever. One time I didn't do it. The next day they're all like half on the floor. So think of it that way. They're putting a little bit of fluid in the balloon, but it's not to like fill it like a water balloon. It's just to give a coating to the inside of the balloon. Well, the surfactant inside the alveoli is similar. It's just a little bit enough of a fluid. And what it's going to do, it's going to keep that alveoli open and allow for gas exchange. So the surfactant doesn't interfere, but this is where, at the alveoli and capillary, this is where oxygen is diffused in to the blood and CO2 goes the other way. So after the alveoli, when the oxygen is coming to the alveoli, it's still external respiration. When the oxygen moves into the capillary and CO2 goes out, that at the capillary level is internal respiration, but this is still external at this point. Now, let me talk about a little bit of the difference between alveoli, and if you look in this picture, the words are small. The alveoli, we kind of talk about this as the alveoli, An alveolus is singular. So an alveolus is meaning one. The alveoli is that. And then sometimes you have an alveolar sac, and that is a cluster of alveoli. So think about like a bag of grapes. If you get one grape, that's an alveolus. If you buy the alveolar sac is like the bag of grapes, and each grape is an alveolus. So at the end of these bronchioles, they branch into alveolar ducts, and the alveolar ducts go to sacs of alveoli. So you have bronchiole, alveolar duct, alveolar sac, and then I will talk about what happens in one alveolus. But these are supposed to be air-filled. They are supposed to contain surfactant. And between the alveolus and the capillary, that's where oxygen and carbon dioxide get exchanged. Now, I'm going to talk about, let me just mention something. If we have an animal that has pneumonia is typically pneumonia is associated with a respiratory infection, but it's when you get fluid in the lungs, it's typically purulent or pus, or but when someone has pneumonia, and sometimes, you know, they cough up phlegm, and sometimes it can be yellowy green. I mean, now pulmonary edema would be an animal that has fluid in the lungs, and it could be clear. It doesn't necessarily need to be, you know, when I think pneumonia, I think of a cold and an infection that goes into the lungs. Pulmonary edema can come from heart disease, heartworm disease. There's conditions that can cause pulmonary edema, and that fluid isn't causing like an infection. There's just fluid where it's not supposed to be. But if there's fluid in these sacs, oxygen and carbon dioxide can't exchange. That's the problem. So if there's an animal that has, sometimes animals will get pneumonia in very small area of the lungs. Well, they have other lungs available. It's when it takes over too many of the lungs that it can be a problem. And speaking of the lungs, they actually are shaped like this. It's kind of odd. It's almost like a cone. This up here is cranial, and this is caudal. So the lungs, because the cranial thorax is narrow, and then it goes wide. So they look like a cone in the middle, and as they go back. And the most caudal aspect here touches the diaphragm. So the lungs extend from the cranial thorax all the way to the diaphragm. They take up a good amount of the thoracic cavity. And then if you remember, in between here, so here's the trachea, underneath those lungs is the mediastinum, and that's where the heart is. Remember I said the heart lies in between the lungs. You are looking dorsal. This is looking from like the top of the thorax down. So if we flip this over, there'd be like a space there where you would find the heart. And they are supposed to be light and spongy. They're air-filled. So they're actually not supposed to be very dense. They're supposed to be spongy. Now these are lungs. The reason they look like this, you can take lungs out and preserve them and plastinate them. It's kind of, it puts in a plastic type material. So these are lungs post-mortem that have been plastinated, you know, for models. Now the lungs actually have lobes. So it's not like one lung on one side, one lung on the other. We have lung lobes. And if you look, they have grooves. So this is one lung here. As you can see, here's a lung. And you see this gap. Here's another lung. And there's a lung underneath there. So when you look at them, they kind of overlap each other. But you can, you know, look at them by their grooves. But they all kind of move together. Now, internally, each lung has a primary bronchus. Now, if you remember when I said the trachea goes down, it goes into a right and left bronchus. Now, the right bronchus is going to divide into you know, the bronchi that are going to go to those lungs. And then there's going to be bronchi that go to the lungs on the other side. There's basically, most species have 3 on the left and 4 on the right, except the horse has 2 and 3. So the horse has 5, 2 on the left, 4 or 3 on the right. But I just want you to know 7 lung lobes. There's 7. So an animal can have damage or cancer to 1 lung lobe, and they've got other lungs that are going to pick up the slack or pick up the work. So, you know, they're not dependent on just 1 lung, so to speak. And then the hilus is, if we look at the lungs underneath, where the blood supply, because remember, coming into the lungs, first of all, you have the trachea and the bronchus. And then you have the blood supply coming into the lungs. We've got the pulmonary artery coming into all the lungs that's going to branch. And then you have the pulmonary veins that are going to leave the lungs and go back to the heart. Well, there's a central part underneath the lungs where all of that comes in, all the blood vessels, the nerves, and the bronchi, and that's considered the hilus. So underneath is you have the hilum, or the hilus of the lungs. But that's, again, you're going to find the, you know, the blood vessels, the lymphatic vessels, the bronchi, and that's kind of where everything connects. I'm going to show you, let's see if I can, see if my computer is going to do this again. Let's see. Give you an idea on the size of horse lungs. Now, these horse lungs are taken out post-mortem. And hopefully you can see this okay. Now, what you're looking at here, they have these horse lungs out. Now, when lungs are compressed, oh wait, do the alveoli? To some degree, yes. They don't, Catherine, they shouldn't completely collapse. They should always be a little bit inflated, but they are going to expand more with inhalation and compress, because the lungs compress, so they compress, but they leave like a little bit of, they still have a little bit of volume, if that makes sense. It's really the lungs moving that expand them and contract them, yes. So lungs, when they are flat, are kind of like a dark brick red. You're going to see these lungs, what they do is they've got a hose in the trachea, and they're going to inflate these lungs. You can see how they're turning pink. Now that's what they're supposed to look like. But you see how light, even though they're big, like they're just like big sponges. So these are areas that are all, so that would be still compressed lung, but they're getting air. This is another one that's short, but So you can see how big these lungs are. So even though they don't have as many lung lobes as the other species, they accommodate a lot of space. And this is what they're supposed to look nice and inflated and healthy. You could see what they looked like when they were compressed. So that gives you an idea of their size. And let me see if I can find, there was another picture I was looking for. But here's an idea. Here's kind of like the underneath of the hilus, what I was talking about. So you've got the trachea, and then they split down here into the bronchi, those two being two, the other lungs, and this would be that hilus. And the heart would be, looks like this is probably the pericardium, and the heart was in there. So just to give you an idea of where things are in the chest. Okay, let's, okay. So now, what is really happening when oxygen is brought into the trachea and it comes down, here's in this picture, here's a terminal bronchiole, which is going to go to alveolar ducts. Here's an alveolar sac, air-filled sacs. Now look at this picture on this, or look at this one. You can see all these little red lines. Those are the capillaries. Those are the capillaries that are surrounding the alveolar sac, because this is where the gas exchange is going to occur. So, and you can look in this picture, here is a red blood vessel, which is a pulmonary arteriole, and then here is a pulmonary venule. So what happens is deoxygenated blood comes into the heart from the right ventricle. Remember, it goes right ventricle, it goes pulmonary artery, then it's going to go to a pulmonary arteriole, it's going to go down to a capillary, remember? And then once it's at the capillary, it's going to give the alveolus, because this, even though this is red, remember, because it's pulmonary, it's bringing CO2-rich blood, carbon dioxide that's in the blood. It's going to come here, enter the alveolar sac. The CO2 can then get exhaled out this bronchiole, but then the animal just inhaled. So then the oxygen that is in here is going to diffuse into the capillary, and then that's going to go through the capillary to a pulmonary venule, to a pulmonary vein, which is going back to the heart. And that's what happens in pulmonary circulation. So this is where pulmonary circulation occurs. So you have this capillary network. Remember I said at an arteriole or a venule, we do not have gas exchange. That is just carrying the blood to the capillary. And all of exchange of nutrients, waste, oxygen, carbon dioxide happens when they get to this capillary. And this carbon dioxide and oxygen being exchanged is the internal respiration. So now we've achieved internal respiration. I think that's enough to talk about today, because I want to get into the thoracic cavity and thoracic pressure, but and I'm going to get into this more. This is an important slide because it talks about what we're going to be explaining in depth towards the end, but I think right now I will stop there. My computer, do you have any questions? So the surfactant purpose that someone just Colin asked is it helps keep the alveolus open, so it helps keep that air sac open, and it helps oxygen carbon dioxide diffuse. So it helps with inflation and helps with diffusion of gases. So there should, and like I said, it's almost just a coating. It's not like, it's not a large amount. It's just enough to coat kind of the inside of that alveolus. Okay. Are there other questions?